Good morning, and now we come to the last topic of our top 10 topics in clinical cardiology 2020, a virtual conference. And I hope it has been very beneficial and educational to all of you. My goal in next 25 minutes and so will be to give you top 10 recent advances in coronary intervention. And as you know that I always start my presentation by giving a tribute to the father of angioplasty, which is Andreas Grundtvig, whose dream was the catheter-based percutaneous treatment of vascular disease in alert and awake patients. And of course, I added with utmost safety. The top 10 advances which I will be presenting, they come from many articles, many studies, many papers which are presented or published. The purpose of including those articles are that they are revolutionary, have a significant observation, widespread acceptance, and changes our clinical practice. Let's start with the first, Taylor PCI. It is a genotype-guided antiplatelet therapy choice. As you are all aware, that clopidogrel is the inactive agent which is activated in the liver by various cytochrome 450, the most prominent being CYP2C19, and makes it the active metabolite. And what has shown that in many patients, many people, there is deficiency of CYP2C19, and that occurs this minor allele frequency up to even 35% in the Asians. So what will happen in those patients? Your clopidogrel will not be effective. And what studies have shown that the patients who have deficiency of CYP2C19, they have a higher cardiovascular event. These were the multiple studies which were presented about 15, 20 years ago. With that note, the FDA recommended, give a black box warning that those who have carriers of 2 loss of function allele, that is what those patients should be given another agent instead of clopidogrel that is more stronger, ticagrelor or prasugrel. To see whether genotype testing, which is available now at a point of care in the cath lab, results can be available within 0.5 to 1 hour. It's a saliva test and gives you whether patient is a carrier or not. And if it's a carrier, then you give prasugrel or ticagrelor. If it's not a carrier, then you continue clopidogrel versus usual care. And this is a small study of ADAPT PCI of 500 patients showed that using genotype guided therapy did not make any difference. But we needed to do a multi-center large randomized trial, and that was the Taylor PCI, which was the genotype guided selection of oral P2Y12. And this was a large trial of 5,300 patients, half in the genotype guided therapy, half in the conventional therapy. And what they did is, in the genotype guided therapy, patients who were CYP2C19 loss of function, those received, the majority received the ticagrelor, and some of course still received clopidogrel. In the other group, which is conventional, the testing was done later, and those who were also the CYP2C19 loss of function carrier, they were given usual treatment. And what did we find? Overall, the genotype guided therapy had a trend towards lower death, MI, and stroke and stent thrombosis, but had a higher bleeding rate. So it still was a trend only, and other individual endpoints are shown here. So overall, it shows that genotype guided therapy did not make a difference. And that was the basically conclusion, and has a very nice editorial that we are not ready to do a routine genotyping to guide our antiplatelet therapy. The second is the defined PCI and Forza imaging trials of PCI. As you know, that in order to improve the outcomes of PCI, many adjunct, whether it's a physiological guided or the anatomical guided with the IVUS and OCT, are being done to improve our outcome. So defined PCI was the blinded physiological assessment of residual ischemia after successful angiographic PCI. Why? What is the background? Because studies have shown that even after successful PCI, some of the patients still have FFR of less than 0.8. And you can see that if you want to optimize, you can of course post dilate, put additional stent if you know in these cases, which happens in 10 to 20% of patients. Also, it was shown that these patients are associated with those who have higher residual FFR, they're associated with higher event rate. So clearly there is a correlation of a higher residual FF means a significant FFR less than 0.84 or otherwise as 0.80 have a higher event rate. So question is, how often do we encounter routinely? And this was the main objective of the defined PCI trial, that rate of residual ischemia defined as IFR of less than 0.89 after operator assisted successful PCI. And of course, they found that after the point, all patients had a IFR of 0.89, had an intervention, and then had IFR pullback at the end. Operators were not, they were blinded. They were not told what were the results were. And what we found in this study, that pre-PCI IFR was 0.69, became, as you can see here, 0.93 post. But many patients, if you take the cutoff of 0.89, some of them actually FFR was less than 0.89. So clearly it appeared that about 24% of patients, there was a residual ischemia still based on the IFR. And majority of those were the focal. When they did a pullback, it was a focal, whether it's an unexpanded stent or dissection or residual lesion, while in 18% was diffuse. So majority of them had focal. So you can make a point that if you can take care of that focal residual ischemia, you'll improve the outcome. And that has led to this major trial called Define GPS, which is the IFR guided therapy versus standard of care. And we'll know the results in next few years. In the same field, also angiographic versus FFR guided from the SCAR registry showed that in large number of patients, by using FFR guided PCI, decreased mortality over 10 years. So 22.7 versus 30.2 seems to be that clearly the FFR should be incorporated in the routine armamentarium. And it happens because by FFR will identify the vulnerable plaque, which is only 50, 60 or 70%, and also will reduce overall ischemia and decrease the stent use. Then question comes, is FFR better or OCT better? So we have a trial called Forja, that FFR assessment, then FFR guided PCI or OCT assessment. They have criteria for OCT optimization. And what they found, basically, the major adverse event or angina status did not change, was identical between two, whether it's FFR guided PCI or OCT guided PCI. Yet, few other things which happen, the procedural cost, length of stay, and total cost of the procedure seems to be lower in the FFR guided PCI. So you can make it a point that FFR should be the routine in our interventional armamentarium. The iLumen 4 will give the final answer whether OCT guided PCI in the complex high risk clinical or lesion characteristics versus angio guided PCI in 2,500 patients with primary endpoint of 1 year target vessel failure will know in next 2 years. Then comes the THEMIS and THEMIS PCI trial of ticagrelor in diabetic patients. So we have tried many other secondary agents in addition to aspirin, like clopidogrel. So basically, knowing that ticagrelor has shown to decrease event in patients with acute coronary syndrome, MI, post PCI. So goal was that what if patients who are diabetes and stable CAD without a history of prior MI or stroke, or had a PCI more than 1 year ago, whether adding ticagrelor will be beneficial. And that was the basis of the THEMIS trial. 20,000 patients, half were assigned to ticagrelor, other half to placebo, all received baby aspirin. And basically you see here, primary endpoint was 0.7 lower in ticagrelor group. And of course, the individual endpoints are here with the stent thrombosis 0.3 lower, but at the cost of significantly higher bleeding, including the intracranial hemorrhage. So you can say that, yes, you have little benefit in terms of ischemic endpoint, but you have a higher bleeding rate. So therefore, conclusion was that you have a trade-off. So routinely, I would not recommend giving a ticagrelor to the diabetic patient with a stable CAD. Now, within that group, there was a sub-study, was the THEMIS PCI. That what if the patients of those 20,000 who had a PCI, what happened to selectively to those pre-specified group? So half, 57.8% of the PCI group had ticagrelor, and other half got just the placebo, and the individual type of strategy as shown below. And basically, the observation was kind of similar what was the main THEMIS study. That is, by giving ticagrelor, those who had history of PCI did have a lower ischemic event, but much higher. Remember, difference was 0.7. Now the difference is 1.3, significantly lower stroke rate, lower MI rate, significant. While patients who did not have history of PCI, there was no effectiveness of ticagrelor. Now, at the same time, if you go to the bleeding, I know we were worried about the bleeding in the main Themis trial. Here also bleeding occurred, but no longer the intracranial hemorrhage or fatal bleeding. So therefore, you can say that selected patient with the diabetes who had prior PCI, who had no indication to continue ticagrelor, may benefit as long as you are concerned. Just take care of the bleeding, which can occur still in some percent of these patients. And this actually put it together. Patient's history of PCI, the net clinical benefit favors ticagrelor along with baby aspirin, and no history of PCI was no different. Question always comes, what if you would have taken out the aspirin from this armamentarium? Maybe would have been lower bleeding, and I'll come to that point a little later. So we also know now we have the anti-reversal agent for the ticagrelor, and you will be soon hearing about it, and it can rapidly neutralize the effect of ticagrelor. So going to the next level is the Augustus trial of NOACs, basically warfarin, which we know has been done of various trials combining where there is need for anti-thrombotic therapy, Bush trial, Pioneer AFib, PCI, Redual PCI, all of them have looked into various combination and found the best combination was the vitamin K antagonist or NOAC plus one antiplatelet therapy. And that basically had led to the second part from the agent which the Augustus trial to see whether apixaban is non-inferior to vitamin K antagonist in patients who have AFib and ACS or PCI, and also whether you can take away the aspirin. Is there any additional advantage of aspirin? So twofold question. So here, all patients with the AFib who needed a PCI or acute coronary syndrome, given apixaban 5 milligram twice a day, patient special subgroup got 2.5 twice a day, or vitamin K antagonist, and 2x2 factorial design got aspirin or placebo in each group. And what did we find? Once you compare apixaban with vitamin K antagonist, superior in terms of the lower bleeding. And if you take aspirin, turns out to be that aspirin has no advantage. Only the bleeding was significantly lower, of course, once you don't give aspirin. But now question is, what if you combine both? And as you see, of the four combination, the best combination was apixaban with placebo is the lowest bleeding, and vitamin K plus aspirin has the highest bleeding. So that we understood. So vitamin K antagonist, when we use the antiplatelet therapy, we usually give clopidogrel, don't use aspirin. But overall, it seems to be that you can drop off aspirin even in these patients with acute coronary syndrome and patients who have PCI. And this was true even you have medical management of ACS or PCI or elective PCI. Though seems to be that we are going away from aspirin, and then come back to this point a little later. Then the Safari STEMI trial of radial versus femoral access. I know numerous trials have been done to evaluate the femoral versus radial, and it has become class 1 indication, having a lower mortality in patients with STEMI or acute coronary syndrome radial access because of lower bleeding and of course the lower mortality. Matrix trial was one of them, and this was the latest recently conducted trial from Canada called Safari, and basically they took all the expert centers for both femoral as well as radial and took patient with STEMI and randomized radial versus femoral. And as you can see here in this trial of one of the large trial of 2,200 patients, there was primary outcome of mortality was no different at 1 month, and secondary outcome of reinfarction, stroke, or death was no different. Also, other endpoints of stent thrombosis or bleeding, which was one of the plus points for the radial, we were not observed in this trial. Why? Because they're very expert operators. So this actually puts it together that yes, even femoral is okay in STEMI patients, and of course suggests that what require is the good vascular access, whether femoral or radial, and in this trial, radial did not add to any better outcomes. And this actually puts into the various meta-analysis which have been published in this field. So next is the Excel trial, PCI versus CABG of unprotected left main 5-year results. As you all recall, the 3-year data were presented of a patient with a syntax score less than 32 with unprotected left main, Science versus CABG, and 3-year data were presented 2 years ago and now presented 5-year. Overall, death, stroke, and MI at 5 years was not different. As you can see here, 22 versus 19.2. But very interesting observation that first month, actually PCI is better, had a lower event rate compared to CABG. From 1 month to 1 year, they were both identical. there was no difference. But after 1 year to 5 years, clearly advantage of the cabbage. So clearly, you can look into that when we have a patient to encounter, what is the life span of that patient, then you can make the decision on these patients. Individual endpoints are here. Overall, the death clearly was higher in the PCI group versus cabbage. And of course, the stroke was non-statistically numerically lower. Rest are shown, except that higher revascularization, which we knew will happen in the PCI group. Also, if you take the graft occlusion or stent thrombosis, definitely was much lower in the PCI group. So this actually, these are the old recommendation. Class 1 is a hard team discussion, whether United States versus Europe. I think all these guidelines will change after the Excel trial 5-year results. I expect that some of the low risk may become class 1 indication for the unprotected left main PCI also. So clearly, I also want to just highlight a lot of controversy on this field. Also, at the same time, there is a lot of meta-analysis have been published, taking all the randomized trial, comparing PCI versus cabbage for death, MI, stroke, basically no difference overall, and unplanned revascularization definitely is against PCI. In the same field, that the DK crush, what should be the technique? Do you use the routine provisional stenting versus 2-stent approach with the DK crush technique? Earlier data were presented for 1 year, then 2 years, then 3 years. It shows that DK crush technique is superior to provisional stenting as shown here, and along with the lower stent thrombosis and the TLR and so. So it seems to be, once you plan the bifurcation left main stenting, DK crush is superior to conventional. Or only thing is that there was no comparison with the mini crush, which many people use. In the same field, also there is data that volume drives outcome for unprotected left main PCI. And this is a study basically showing that low volume, intermediate, and high volume operator, 6, 24, or 38, they have a half decrease the mortality from 4.1 to 2.1 in the experienced high volume operator. So clearly, that is where you should be looking for. And the additional the data came is in terms of imaging. This is from the British Cardiovascular Interventional Society, that imaging, which is done in about the 12 to 13% of patients. But overall, event rate is significantly lower in the imaging guided PCI. So this is, we are talking about mortality, 8.9 1 year versus 12.9. So imaging guided for unprotected left main is the right thing to do. And that is what soon, in my opinion, will become class 1 recommendation. Right now, it's still is a 2A. So then moving on is the complete trial of STEMI PCI strategy. We were aware in last 8 years, the concept, the culprit PCI has gone to the complete revascularization based on the PREMI, CVI culprit, and permeability trial, and all of them in a different combination, whether you do same time or do a stage PCI or FFR guided PCI, all led to the one common notion that complete revascularization in STEMI patient is beneficial compared to culprit vessel PCI. Now that has led our recommendation from class 3 go down to 2B for STEMI for the multi-vessel PCI. So this complete trial was the largest of trial of its type, and evaluate the strategy that whether complete is revascularization better versus culprit, and also when you do a complete revascularization, should be done in the same hospital admission, or you can do it few weeks later as a stage intervention. Again, it's a 4,000 patient trial, and the patient, half of them in the complete revascularization had a PCI done within same hospital admission within 2 to 3 days, or we did after 3 weeks, and so. So what is the results? Basically, the complete revascularization had the 2.7% mortality versus 3.7. So 1% decline reduction in mortality. Number needed to treat is 37. Very, very relevant observation. And if you take the individual endpoints are shown here, significant reduction in MI, and of course, repeat revascularization. So seems to be complete revascularization is a way to go in patient with STEMI. Now, whether you do initial hospitalization or you do it after initial hospitalization, as you can see here, it did not make a difference. Complete revascularization, event rate remains same, 2.7, 2.7, 3 or 3.1. Even you put into a ischemia-driven revascularization, but seems to be that the complete revascularization done at time, initial hospitalization, or in a stage fashion within 1 month is appropriate. Now that actually will change the guideline. I am hoping in our updated guideline soon. Now, this is a little different than cardiogenic shock. Cardiogenic shock, the shock trial, basically culprit shock showed that doing a multi-vessel PCI in cardiogenic shock, which was our concept 20 years ago or 10 years ago, has completely changed after the culprit shock. That the only the culprit PCI was have a lower mortality at 30 days compared to the full or multi-vessel PCI. And of course, that the renal replacement therapy was also the same. So it seems to be that all the concept of the cardiogenic shock, you do only culprit vessel PCI. And this actually it will lead to the 1-year outcome, as you can see here, in favor of the culprit vessel PCI in cardiogenic shock. And I think this already had changed from the 2A to class 3, that cardiogenic shock, you do only culprit vessel PCI. Going to the next one is the ISAR React 5 trial or prasugrel or ticagrelor, and that basically lead to of course, we know that in Triton Timmy 38, the prasugrel was better than clopidogrel. In Plato, the ticagrelor was better than clopidogrel, but at the expense of higher bleeding. Both studies shown higher bleeding. Now, what about comparing these two agents? This is a small trial, Prague 18 of 1,200 patients, randomized to prasugrel or ticagrelor, and found no difference. So we did have some background that amongst these two agents, there is no difference. Now, this was a major trial from Germany, ISAR React 5, comparing ticagrelor to the prasugrel to patients with acute coronary syndrome, and majority of them were non-STEMI and STEMI, so true high-risk patients, and of course some have unstable angina, and basically found that the ticagrelor was inferior to prasugrel as a primary endpoint of death, MI, stroke, and stent thrombosis, as you can see here. Clearly, the lower event rate in the which is height of the blue bar prasugrel, and there was no difference in bleeding. So clearly, prasugrel was superior to ticagrelor and no difference in bleeding. I can tell you, I have been a big believer of the prasugrel. I have been using quite a bit, and now since the trial, a lot of switch has taken place, and this puts it together in terms of the clinical endpoints at 1 year, death, MI, and stroke in favor of prasugrel over ticagrelor, and no difference in bleeding. Now, also, the idea is go away from more aggressive, more potent P2Y12 agent, particularly the patients who are at high risk. This is the popular ACE trial, elderly patients more than 70 years with non-STEMI, and they compared clopidogrel versus ticagrelor and found that clopidogrel was superior to ticagrelor in terms of lower bleeding without any difference in the ischemic endpoint. So you can recommend that now. So coming back to the one of the major trial of 2019 and 20 will be twilight trial of aspirin discontinuation. Now what it is, we all know that in the beginning, after the PCI, we really need a strong agent, DAPT. After 1 year, probably we don't. 3 to 6 months, it probably is the 8 or 6 to 12 months, we may decide whether continue or not. But most of the trials which are done, they have abbreviated the duration of PTY12 to 3 to 30 months. Many trials were done to answer that question. But what if we still know that bleeding occurs? So what if that we continue the stronger P2Y12, particularly in the twilight trial, will be ticagrelor, and take away the aspirin. So whole issue was that maybe aspirin causing no benefit, rather harm. And we know that initial trial of large patients of 16,000 patients, global leader trial did show that by removing aspirin, you did have a trend towards a better outcome of death, MI or death, and without any difference in terms of stent thrombosis or so. Seems to, and of course the bleeding was no different. So it seems to be that dropping aspirin after 1 month in these patients was completely fine. Then there was a Glassy study that was the adjudicated clinical outcome at 2-year follow-up from the same global trial, and message was same, basically that dropping aspirin would lead to a significant reduction in death, MI, stroke, or urgent TVR. And of course, no difference in bleeding. So seems to be that aspirin stoppage is fine. Then there were 2 other trials were done for the PCI. One was a smart choice where 77% were clopidogrel, 23% were prasugrel or ticagrelor, and in these patients, the 3 months of DAP, and after that, the aspirin was stopped. So basically what we found that monotherapy after 3 months versus DAP, clearly in terms of primary endpoint was no difference, but you have a lower bleeding. Same, the similar concept was the stop DAP2, in which the aspirin was stopped after 1 month. And this is the second agent is clopidogrel, not the more potent P2Y12, and saw the similar message. That is, that overall you had no difference in ischemic event, rather you have a significantly lower bleeding. So seems to be that aspirin is a culprit and may not be needed whether you are using clopidogrel or in the global freedom trial using the ticagrelor. That lead to the major trial by Dr. Roxana Mehran. The trial was conceptually designed at Mount Sinai, implemented globally with the multiple centers and the multiple countries. And the trial hypothesis was that patients undergoing PCI who are at high risk for ischemic or hemorrhagic complication and who have completed a 3-month course of DAPT with ticagrelor plus aspirin, continued treatment with ticagrelor monotherapy would be superior to ticagrelor plus aspirin with respect to clinically relevant bleeding and would not lead to any ischemic harm. So concept basically was that taking away aspirin after 3 months, will it decrease the bleeding? That one. Secondly, will it increase any ischemic event? And that was our primary and secondary endpoint of the trial. Trial done conducted very rigorously, and it was the first of the placebo-controlled trial which done in this field, and basically saw that BARC 2, 3, or 5 bleeding was significantly lower in the ticagrelor monotherapy group. This is 3 months, everybody got aspirin and ticagrelor. After 3 months, no aspirin, and significantly lower. And these are the individual endpoints of the bleeding. And now if you go to the ischemic endpoint, basically death, MI, and stroke, you did not find any difference. As you can see here, remained identical. So same, whether it's a stable syndrome, acute coronary syndrome benefit. There was another trial called TICO trial from Japan, within patient with acute coronary syndrome getting PCI. They also stopped the aspirin after 3 months and found that overall 12 months primary outcome in favor of stopping the aspirin after 3 months. And of course, benefit occurred after 3 months when the aspirin was dropped. And in terms of lower bleeding, while the MACI remains the same, rather trend towards the ticagrelor monotherapy. So seems to be the field that changed, and aspirin can be dropped between 1 to 3 months after PCI. That leads to our major trial and top 10 advance of the recent interventional cardiology, the ischemia trial of invasive versus conservative treatment. And this is, background is, we know that a stable coronary artery disease, PCI versus medical therapy was identical as we knew in the COURAGE trial. Although within COURAGE, there was a nuclear sub-study that showed that PCI do a better job of reducing ischemia more than 5%, and reduction of 5% ischemia drives the lower event rate. So that was the basic concept. And that multiple trials of PCI versus optimal medical therapy of risk of mortality and risk of MI have shown no difference. So that led to the ischemia trial, that what if we take a moderate to severe ischemic patient and try medical therapy or do the invasive approach. All these patients had a blinded CTA to see if there is no coronary artery disease will be excluded or left main, which selectively should go for revascularization, were excluded. So clearly, these were the patients with the invasive strategy with optimal medical therapy and cath, conservative strategy, optimal medical therapy, and cath only for optimal medical therapy failure. These all patients had to be stable. Unstable patients were not enrolled. Very rigorous trial. Eligibility criteria, exclusion criteria took 9 years to complete this trial of 5,000 plus patients, and 2588 randomized to invasive and 2591 were randomized to conservative strategy. And of course, majority of these patients have a moderate to severe ischemia. And rest of the risk factor modification were very aggressive and very appropriate, which you'll see in the most of the trial patients. And also, whether patients were assigned. So patients who assigned invasive treatment, 96% got it. In conservative, 28% had a crossover and required revascularization in 23% and 80% revascularization in the invasive group. 20% did not require revascularization in the invasive group because they were insignificant disease or they have the extensive disease unsuitable for any mode of revascularization. 74% got PCI, 26% got cabbage, and basically the outcome was conservative versus invasive strategy at 5 years. Although numerically lower, about 2.2%, but p-value was 0.34. And of course, you can see that at 6 months, identical. After that little separation, I expect that maybe at 10-year or 7 or 8-year, we'll have a bigger separation as shown here. So now if you take a cardiovascular death or MI, the similar story, which was shown for the overall endpoint. And for MI alone, there was a little interesting observation that in the invasive strategy, higher MI early time because of the procedural MI, but after 2 years, as you can see, the curve just started separating in favor of lower MI in the invasive group. And if you make it see here, that spontaneous MI was much lower in the invasive group. And that's a very remarkable observation that stable CAD patient, PCI reduced the spontaneous MI. And so conclusion basically was that in patients with the ischemic patient, whether you try invasive strategy or conservative is fine. Primary endpoints were no different. But yes, the invasive strategy reduced the incidence of spontaneous MI compared to conservative strategy. And it is the first trial which showed that. And of course, the long-term benefit of this may will require another 5 years to show. There was also quality of life. Patients particularly filled up the quality of life questionnaire, which is done basically the SAQ score, that patients, particularly on the invasive group, anytime you go on the right side, as you can see here, the people who have invasive therapy, and particularly, as you can see, the ischemic at 3 months, 12 months, or 36 months, more you are coming towards the zero. That means they're having a lesser ischemia. So that is what basically saw in patients with the monthly angina score. Now, if you have no angina, then there was no difference in invasive approach. So basically, the more you are going away from the median, that basically that better was the quality of life score. So seems to be that the relieving angina invasive strategy was superior. And of course, we have a lot of media publicity on this field, and of where this field will go is still need to be seen. So basically, from interventional cardiologist perspective, I would say that we need to decide based on what patient needs. It is appropriate, even in ischemic patient, to maximize their therapy and do PCI as a once the symptoms are not controlled. But at the same time, if patient wants to relieve angina, ischemic directed revascularization was superior to medical therapy. And so this leads to our all top 10 advances of interventional cardiology. If I had to put it together, some of the message that what did we learn in these trials, the radial PCI in STEMI, ticagrelor in patients with diabetes and genome testing and PCI, there was no benefit. And then FFR guided PCI, clopidogrel in the elderly, invasive RX in ischemic heart disease, one benefit. Conservative RX in ischemic heart disease, PCI for left main, multiple STEMI, NOAC alone, definite plus, and real plus was prasugrel in ACS and aspirin drop in 1 to 3 months post PCI and continue ticagrelor to become better interventionists. And of course, these are our recent data, the highest volume with a great safety, lower 30-day readmission at Sinai. Also just want to tell you trend in the America, overall there has been a almost 40-50% decline in revascularization, whether PCI or CABG. I think this is the power of medical therapy which has been shown. We actually continue to teach globally in 138 countries, over 12,000 people per month with the CCC live cases showing the complex case. And I really thank my cath lab team to get us where we are, provide the best care to a large number of patients here. And thank you very much.